with the fifth P being persuasion, because as we accumulate more and more data, wearable data, blood data, imaging data, genetics data, it becomes imperative to really use the data to persuade folks to do the right thing. Many of you may know that Dr. Hood is a member of the National Academy of Sciences, the National Academy of Engineering, and the National Academy of Medicine. Of more than the 6,000 scientists worldwide who belong to one or more of these academies, Dr. Hood is one of only 20 people to be elected to all three. Dr. Hood played a role in founding 15 biotechnology companies, including many that you know very well, including Amgen and Arivale, which I think is really one of the first precision medicine P4 companies on the planet. And I think we've continued, obviously, in that tradition with human longevity. And again, the author of numerous books, including most recently, The Age of Scientific Wellness. So with that, Lee, I'll turn it over to you. I know that you have a presentation for our members, and then we'll, as we always do, conclude with about 15 or 20 minutes of questions.
Sounds great. Okay, I'm going to talk about radical health and the Human Phenome Initiative. And I use the term radical health because I argue that the Human Phenome Initiative, we'll discuss in a moment, will transform healthcare in the sense will replace our current focus on disease care with one on wellness and prevention. And I would argue that's one of the most radical changes ever in medicine. And of course, what's going to drive this whole effort, the strategy, is a data-driven health for individuals. Now, it was probably 1970 when I was a beginning assistant professor at Caltech, trying to figure out what I wanted to do with my career in the future, that I started thinking about human complexity and how we could approach it. And it was obvious, even at that time, that the complexity was absolutely bewildering and that we didn't have the tools to begin to approach it. And my lab from the very beginning started out with a focus on molecular immunology, which I'd done for many years, and on developing new technologies for the analysis of DNA and proteins. And that venture led to participating in 7 different paradigm changes that I think dealt with the complexities of biology, but framed my view on healthcare and everything. And of course, the first paradigm change was developing over the years 6 different instruments to manipulate DNA and proteins in various ways. And you heard about the most important, the automated DNA sequencer. And that got me invited in the spring of 1985 to the first Human Genome Project meeting. 12 of us got together and opined on whether it was a good or bad idea. We concluded, 1, it was technically possible, but 2, we were split 6-6 on whether it was a good idea. And those opposing opposed it because it was big science, and their worry was big science would take the money from small science. This turned out not to be true. In fact, the Human Genome Initiative transformed small science in hundreds of different ways and so forth. A third paradigm change came with the realization that in doing technology development, one needed an enormously cross-disciplinary environment. And my lab became very big as a result of that. And in thinking about it, I decided it would be better actually to have a department that was itself made up of cross-disciplinary faculty, and tried to persuade Caltech that this was a great place to go. And the biology department there vetoed the idea, I think probably because they were worried about competition. Bill Gates invited me in 1992 to go to the University of Washington and set up the first such department, which we called molecular biotechnology. And it was spectacularly successful in developing a whole series of technologies, including our use of the inkjet technology for rapid synthesis of tens of thousands of DNA fragments that Agilent still uses today. It was clear the University of Washington had a bureaucracy that made it very difficult to start what I really wanted to do, was to build a Department of Systems Biology. So in 2000, I resigned and set up the Institute for Systems Biology and used it to pioneer systems approaches both to biology and disease. And somewhat later, this led to the whole idea of P4 medicine, predictive, preventive, personalized, and participatory. And we actually set up the P4 Medicine Institute that thrived for a number of years before giving way. The next big paradigm change was in the early 2000 teens, 2013 and 14, when I decided I would try and use a genome phenome analysis, and we'll define that in a moment, of individual human beings, and 108 of my friends agreed to do so. And I remember going to Francis Collins and trying to persuade him to support such a venture. And at that time, he said, the role of NIH is disease, not dealing with wellness. You'll never find funding here. But we did the program, and that led actually to the Arivale program, a for-profit company with scientific wellness that we'll talk about in just a moment. And then the final initiative came when, in the midst of being chief science officer at Providence St. Joseph's, a large healthcare system centered in Seattle, I decided to really start pushing the Human Phenome Initiative. And it's this that is going to catalyze the change in healthcare to wellness and prevention. And to do that, I set up the Phenome Health to push this data-driven approach to healthcare and so forth. So these new ideas in every case required new organizational structures. And for the 7 paradigm changes, I started 4 new companies and 5 nonprofits to catalyze the paradigm changes that led to where we are today. I'd argue that health is the most fundamental of all human characteristics, in that it underpins virtually every key human trait. Early development, education, your jobs, your ability to create community, creativity, happiness, and even health span, I think, are all fundamentally improved enormously by lying on a foundation of wellness. And of course, the ultimate objective for scientific wellness, as I've called this, is to generate a health span for many individuals that carry into your 90 or 100s, where you're mentally capable and physically healthy. And we'll talk about just exactly how we plan to do this in the future. In data-driven health, it's the genome and phenome we measure. The genome, of course, is the source code of human development, and it gives you a whole series of potential health trajectories. And these health trajectories, or your phenotype as you go from a newborn to death and so forth, changes dramatically as a result of your own behavior and your environmental exposures in conjunction with your phenome. And of course, that phenotype measured by the phenome, we measure by looking at blood analytes, the gut microbiome, brain and body digital health, assays, and a whole variety more. The other point I'll make about data-driven health is its ultimate objective is a second human genome project, a 10-year proposal to do 1 million people with a genome phenome analysis that, as we'll see later, will lead to a medicine of wellness and prevention. Systems biology is really the foundation for being able to take this data and deal with it effectively. Blood, of course, as we know now, is a window into health and disease. And the different organs in your body give off molecules into the blood, which can be captured and read, thus specifying the state of health in many different organ systems. And we've developed a whole set of organ-specific blood proteins that allow us to quantitate the state of more than 25 different organs. These organs actually are fed into biological networks that underlie disease and wellness itself. And of course, we're now beginning to use all the tools of AI, whether it's machine learning, digital twins, which let us stimulate trajectories of health and disease, knowledge graphs for correlating causality, and large language models, which allow us to deal with complexity in very effective new ways. I'll say a word or two more about that later. And of course, all of this is framed around the features of systems biology. It deals with the whole organism. It's global. We want to get as comprehensive data types, many different types that are both dynamical or longitudinal, can be integrated together ultimately to recreate the hierarchical organization of a living being. And of course, this data-driven vision for health has 3 different features of health that I really want to stress in opening. Wellness, most of us are born in wellness. We transition at some point, all of us, from wellness to disease, which progresses to a clinical entity and generally reverses itself back. What is really important is we've demonstrated with 2 animal model systems and a human model system where we can initiate the transition for disease. We can demonstrate there is an exponential increase in disease-perturbed network. So by the time you get to clinical signs of a disease, the networks are enormously complicated, and most drugs treat symptoms and not fundamental causes of disease. So whether it's wellness or transition or disease, we have, with scientific wellness, the ability to improve wellness through actionable recommendations that come directly out of the data from individuals themselves. We have the ability to identify these early transitions years before disease, and I'll talk about that more later. And we have the ability to use precision medicine to be able to understand disease more fully. And of course, putting these 3 capabilities together, again, is what catalyzes this replacement of a disease focus with wellness and prevention. The real proof of principle for the Human Phenome Initiative, the initial proof of principle, came from Arivale, a wellness company we started in 2015, which lasted roughly 4 years. We acquired 5,000 people. We analyzed them with genome and phenome analyses. So we had an enormous amount of data that we could use to analyze the features of wellness and the features of disease prevention. And the data we used in Arivale was whole genome sequencing, laboratory analyses of proteins, metabolites, and clinical chemistries, the gut microbiome, and finally self-tracking from a Fitbit and the monitoring of lifestyles. This led to more than 200,000 actionable possibilities, and they could be uniquely applied to each individual according to their own data makeup. We also used coaches, and we're beginning to play now with data bots that are actually going to substitute in families for coaches in the future. We publish now close to 30 publications in peer-reviewed journals, and each gives us a snapshot of what wellness and prevention actually mean. And what I'm going to talk about are 6 different examples, stories of scientific wellness and statistical actionable possibilities in the first case. Where, as I said, we initially took 108 individuals and we quantified their 6 different types of big data. And we were able to do statistical analyses that allowed us to correlate more than 3,500 different possibilities. And these correlations of data bits from 2 different data types led to the clinical literature and to the identification of relevant actionable possibilities. And of course, what's really exciting is the 1 million-person project may lead to greater than 10,000 new actionable possibilities. So an enormous increase in what we can actually do. Now, statistical analyses are one thing. Another thing we've done are community analyses, which took these statistical correlations and used an algorithm which operationally snipped the edges of those entities that were essentially the lowest in probability. And what they led to is a series of 70 communities of features that turned out, interestingly enough, to correlate with normal physiology and with disease-related physiology. And here's an example of one of these. It's the community that's exploding out with 13 different examples of the cholesterol community. And what was really interesting is we were able to show cholesterol's negatively associated with thyroxine. And hence, we postulated at this time thyroxine might be a good drug in dealing with cholesterol, only to find out that Lilly was in the final stages of making a drug that does indeed deal with cholesterol in just this way. What was interesting is with 500 proteins, we had 3,500 correlations in 70 communities. When we looked at 5,000 proteins, we got 35,000 correlation and hundreds of seemingly beginning to integrate communities. So there are enormous opportunities for biomarker and just drug discovery at this place. Another thing that the phenomic analysis of blood analytes can do is deal with the problem of drugs that only operate on average in 10% of the people. There was a paper in Nature in 1995 that took the 10 most common drugs and showed that they varied in efficiency from 1 in 4 to 1 in 25 individuals on which they worked. There have been arguments that these numbers are way too low, but I'd say even if they're 50%, in the future, we'll be able to identify the responders and to target the drugs precisely at those responders. And that's exactly where we want to go, saving, up to $500 billion in drug costs in the future. story number two is the prevention of chronic disease through early detection and treatment, as I indicated before. The first case we looked at was a young woman in about 2017 or 18, named Eve, that actually was diagnosed with stage 4 pancreatic cancer. I'll just say that of the 5,000 individuals in the Arivale program, 167 transitioned from wellness to most of the different chronic diseases. What we did with Eve was looked at 4 blood draws prior to her diagnosis, and we were able to show that there were 5 proteins in each of those blood draws that were elevated as compared with the normal control of about 1,900 individuals at that time. We were able to demonstrate that 3 of the 5 of those proteins mapped into disease-perturbed networks that were related to stage 4 pancreatic cancer. The other 2 were totally unknown proteins. So it seemed that we could do diagnoses up to a year and a half prior to the clinical diagnosis that you saw here. We actually looked at 9 additional individuals with cancer transitions, and for every one of them, we had abnormal proteins that mapped into relevant networks that showed up between 1 and 4 years prior to clinical diagnosis. And what's exciting is with the Million Person Project, we estimate more than 200,000 of these transitions will occur, and we'll be able to validate with statistical precision the kinds of early biomarkers, and then begin to actually mediate preventive measures or reversal of therapeutic approaches. And for example, with cancer, one can think of immunotherapeutic approaches that could be very effective at this early context we're talking about. And with a health budget last year of $4.4 trillion, and the fact that 86% of the annual budget is spent on chronic diseases, suppose in 10 years you could do away with half the chronic diseases. You can begin to see the type of savings that would be possible. And with Eve, we actually went on to look at the existence of 9 potential disease-perturbed relevant networks in pancreatic cancer at each of the 4 time points in the blood draw. And we went from 0 at the first time point to 1 in the second time point to 2 in the third time point and to 5 in the fourth time point. And below is shown the exponential increase of diagnostics. And it shows you why targeted therapies that go to patients that already have been diagnosed with cancer almost always are going to hit symptoms and not fundamental causes, and very rarely cure the patients. Healthy aging and health span is another absolutely critical area that we're interested in. And because we had people that ranged in age from 21 to 93, we were able to bin them into 10-year categories, as you can see here, and show that there was more or less an exponential decline in the ability to control the bracketing of the 3 classes of blood analytes that we analyzed: proteins, metabolites, and clinical chemistries. And we use this to create an algorithm or a metric for biological age, that is, the age your body says you are, as opposed to the age your birthday says you are. And the lower you are in biological age relative to your chronologic age, the better, obviously, you're aging. We went on to show that women in the Arivale wellness program lost 1.5 years per year of biological age, and men 0.8 years. So dramatic improvements. And in fact, how much you can lose in biological age is really an interesting question. One of my friends over that 4-year period actually lost 10 years of biological age. Number two, we were able to show that the age of relevant organs, your liver, your spleen, your kidney, and so forth, could be diagnosed with regard to biological age, and they could be somewhat different from your global biological age that came from blood analytes. Disease inevitably pushes your biological age up above your chronologic age, and when you recover, reverses it back down. So we see biological age as a metric that reflects one's age very well, and we're going to be using it in all our future studies to follow wellness. Another metric that turned out to be absolutely fascinating is the biological BMI. The traditional BMI, as you know, is a weight, is an index that's measured by height and your weight, and it gives you good mortality and chronic disease assessments. It has virtually no capacity to capture complex metabolic or physiologic differences, and it misdiagnoses up to 30% of the people. We were able to use each of the analytes, metabolites, clinical labs, and proteins as a biological BMI, and in all cases, they were enormously flexible and more accurate, and they were actually able to classify everybody accurately and to actually even identify 5% of the people that appeared normal by the classic measurement, but were clearly metabolically abnormal. It allowed us to stratify obesity in very different ways with regard to the new obesity drugs and things like that. And it's very responsive to lifestyle interventions, namely changes in diet and things like that. So again, metabolic health can be measured very effectively by this algorithm. The gut microbiome, of course, is a key, and we're at the very earliest stages of what you can do about things. Diversity is a key for health. We do know that. And we can assess the diversity of the gut microbiome by actually measuring 11 blood metabolites. And this gives us the ability to go into biobanks that didn't keep fecal samples and get the microbiome for yesteryear. Number two, we were able to show statins were profoundly altered in two ways. One, you could enhance the positive activity of reducing LDL cholesterol, or two, you could enhance the complicating activity of type 2 diabetes. And there were actually ideal classes of microorganisms that optimize the good and minimize the bad and so forth. And I suspect this is going to be true of many different drugs, and we and others are looking at these now. But most interesting was some of the patterns are actually associated with biological age. And that was demonstrated by the fact all of us at younger ages have core taxa that are, if you age in a healthy way, are almost totally replaced by individually unique microbiome in healthy people. Whereas in the unhealthy aging, one, you don't replace the core taxa, nor do you differentiate in an individually unique way. And it will be fascinating to see how one can manipulate these insights to begin allowing individuals to effectively age and achieve a health span into the 90s and hundreds or so. And the final point, which is almost entirely ignored by contemporary medicine, is brain health, and in particular, brain health that looks at cognitive features that are the very essence of what it is to be a human being: reaction time, depth of field, memory, those kind of things. We're collaborating with Posit, a company that has 40 digital measurements to assess 25 aspects of brain cognition. And what Michael Merzenich, who has pioneered this whole approach, has been able to demonstrate is for the normal individual, your cognitive optimum comes about in the mid-30s, and almost everyone declines thereafter. But he showed that the brain has enormous plasticity and flexibility, and that he could take 1,080-year-olds, and for many was able to restore them back to cognitive abilities that were close to what they should have been at their maximum time. The other feature is he's had more than 250 clinical trials with 10,000 people, and he's been able to show that you can use these physiologic processes to actually predict at a very early stage depression, drug addiction, proclivity, schizophrenia, PTSD, TBI. And there are ways that you can actually do that help in some of these cases. It is absolutely going to be transformational, I think, to instill this in a population-wide basis. So scientific wellness is one type of wellness: classic exercise, diet, sleep, and stress management. And of course, big data-driven scientific wellness is another. And that's where we look at the genome, and as I'll show you later, it has 7 different features, each of which lead to tens to thousands of different actionable possibilities. And with the phenome, we're just beginning to classify all the many different kinds of possibilities that can be done there. But one of the really important things is big data-driven scientific wellness can actually provide deep insights in how to, for the individual, optimize the types of exercise you do and the type of diet that's necessary for you, and how to deal effectively with sleep. So what is clear is traditional wellness that's mediated by clinical labs, imaging, anthropomorphics, and electronic health records, and so forth, is something that data-driven health extends far beyond. The genome can go in new dimensions with actionable possibilities. You can with the microbiome, with metabolome, with the proteome, and with wearable data devices have extensive expansion into what we call data-driven health for the future. And of course, this allows us to personalize for each individual that dimensionality of improvement and then the dimensionality of reduction. So the 6 stories I've told you: scientific wellness and actionable possibilities, the early transitions and their hopeful reversibility, the ability to measure the biological age and biological BMI, the gut microbiome and its potential for health in the future, and brain manipulation, of course, give us an idea of the power of what we can do now and what we're going to be able to do in the future. And this is just looking at the 7 different categories of actionable possibilities in the genome, is bring literally tens of thousands of actionable possibilities to the population in the form of the American College of Medical Genetics, actionable possibilities of variants that can be corrected. Pharmacogenomics, the hundreds of variants that deal with how you process drugs. Polygenic scores that let us, again, assess your risk for disease and in some places intervene. Rare diseases, there are 7,000 that have been defined and many more are coming. The Mendelian recessives, again, a very large number that exist. And the genetics of athletic injuries, there are literally hundreds of variants that deal with these. And ancestry, of course, is another area. Where are we going in the future with the Human Phenome Initiative? We're going to use data that is 10 times greater, 10 to 100 times greater than the data that we used with Arivale. And I won't run through all the things here except to say we will have data-driven metrics, your biological age, your biological BMI, the metabolic assessment of your gut microbiome. And now we have 25 classes of organ-specific proteins we can use to assess different organs. We're going to use, obviously, social determinants of health and self-reporting by patients, as well as the electronic health records in the future. And we actually have new wearables that will be far more effective than the early Fitbit was. And we've put together the 5 different approaches one needs to develop to be able to have a large population of patients that can go through this Human Phenome Initiative platform. Education and recruitment is great. We've spent a lot of time thinking about that, creating the biobank where samples can be stored. And then, of course, the data generation, we, for the most part, are sending it out to let it be done with experts that can do it more effectively than we can. We've built an innovation computational engine for mixed omic analyses that I think is second to none now, and it maps right into the AI techniques that we'll be talking about in just a few moments. And of course, this all puts us in a position to generate tens of thousands of new actionable possibilities with the Million Person Project, and to refine human wellness in a manner that was inconceivable even a few years ago, creating new medical knowledge and insights and new therapies and biomarkers and the like. We've partnered with the Buck Institute for Aging, since we have parallel interests there, with Guardian Research Network in South Carolina, which has access to 50 million patients. And it is this group we'll use to at least begin the Million Person Project. They have electronic health records for the 50 million patients. They lie in 13 different states. They cover African American as well as Latino population, so we can get right mixed populations and so forth. Brain HQ, I've talked about before, and we're collaborating with Google on a number of different things, including their large language model. So the Phenome Initiative, as we see it now, in the short term, has 2 major objectives. One is individual phenomics, and that's exactly what we've talked about here. And we see millions being generated within the next 5 to 10 years. We're talking with several healthcare systems about this, with both the UAE and Saudi Arabia. And of course, smaller practices like HLI are doing a wonderful job in this regard, and we hope to be able to add enormous dimensionality to what they're doing as it becomes economically reasonable. The second thing we're doing is taking the top 4 chronic diseases diabetes, Alzheimer's, cancer, and heart disease. And we're going to do data-rich observational and interventional clinical trials on these to be able to understand them and look very early in the disease at powerful techniques for successful reversal. And of course, the final point is the long-term second genome initiative, 10 years, 1 million people, the return of results in a genome phenome project, which will completely validate genomics and phenomics. And we'll talk more about that in just a moment. So the first study we're doing is we've raised about $25 million to carry out a 3-stage observational study on type 2 diabetes. So we're using 10 million electronic health records to identify individuals at all different stages of diabetes, which has a normal lifespan of 15 to 20 years, and to identify high-risk individuals that have not transitioned, and use those selection criteria to follow 1,000 patients over a period of 4 to 5 years, and look, one, at a definition of the various subtypes that exist within diabetes and the particular transitions each takes to various types of chronic disease, chronic kidney disease, macular degeneration, and so forth. And of course, once we understand that, we can do interventional models. And we plan to do that with the other 3 diseases as well. What about AI? The big idea that we have here is that we can take the individual genome and phenome data and either place it in digital twins where we can make beautiful predictive models as we have for brain health, together with colleagues at several different institutions, or we can use knowledge graphs to tie the data and give it causal explanations for why it is the way it is. And of course, translating digital data into verbal data makes it possible to feed it to large language models. And the real idea here, you can do many things with large language models to improve healthcare. But the one I'm most struck by is to be able to take the individual genome and phenome from each individual and to extract from it prioritized actionable possibilities and to frame them in such a context. You can give them to the patient's physician, one, explaining clearly what they are and what needs to be done, and 2, giving the medical information that justify those actionable possibilities. And of course, what this does, in a sense, is make super docs by this physician AI partnership, in the sense that the AI is in time going to cover every field of medicine and make any of these fields available to the physician, who operationally will become a domain expert in all of those areas, with the ability to treat patients like no physicians ever could treat patients before. So we think the Human Phenome Initiative offers solutions to the 5 contemporary challenges of healthcare: quality, aging population, explosion of chronic diseases, diversity, equity, and inclusion, and exponentially increasing costs. And I've talked about how each of these, I think, can be addressed by this data-driven approach. And of course, the long-term initiative that we talked about here is going to validate the whole idea of replacing a disease-oriented healthcare with wellness and prevention. Because one, it's going to validate that wellness can be increased for individuals in striking ways. 2, it's going to lead to cost savings, both with regard to chronic diseases and using drugs effectively. And 3, it's going to eventually trigger a technology that will bring wearables to the home mediated through cell phones that I think is going to make it possible to, in the future, think about democratization of healthcare and taking it to underdeveloped countries like the African countries. So what are the benefits? 1, it's going to shift, as we said, our current disease focus to wellness and prevention. Number 2, as I just mentioned, eventually we'll democratize healthcare by bringing it to the home and simplifying enormously its dimensionality. And 4th, I think AI is absolutely going to transform in every way what we can do as physicians to treat and improve the healthcare of individual patients. The team we've gathered together has expertise in very broad areas and has done a remarkable job over the past 3 years or so. And I just want to say, not only have we published the book that was mentioned, but we recently published a Nature Genetics review article on the transition from genomics to phenomics in personalized population health that lays out how we're going to do this and where we're going to be doing in the future. So thank you very much, and be glad to answer questions in the time that's left.
Thank you so much, Lee. We have many questions, and we won't be able to get to all of them. And I always learn something when I hear you speak. So again, thank you on behalf of all of our members. I'm just going to moderate, Lee, some of these the questions. There's a few that have come up more than once. One, and you alluded to it earlier when you approached, I guess it was Francis Collins way back then, about funding for phenomics and kind of wellness, and he said something to the effect of, don't come to us, we specialize in sick care or sickness. And we obviously know that is the reality even today in 2024 of our healthcare system, that it's still very sick care oriented. My question, and the question that came up in a couple different threads here, is it's a bit of a chicken or the egg, cart or the horse question. What is it going to take, for the NIH or the FDA to, radically invest in precision prevention, and really in some ways characterize aging as a disease? Is that going to be, the initiator, and from that will come, NIH dollars to go towards this? Or conversely, is it that we're going to have to show, maybe through companies like our own, with observational longitudinal studies with outcomes, that then that data can then be used to justify an NIH approach or an FDA approach to characterizing aging as an actual disease? What's your take on that?
My take on that is NIH won't provide the resources that are necessary because they think in units of $500,000 a year, and that's never going to handle these data-rich problems. ARPA-H is a new organization that just got started this past year, whose mission is to transform health and bring it to individuals. And that's exactly along the lines that we've talked about here. So my prediction is there, and it had at least $1.5 billion worth of funding in the first year, and they proposed even larger funding in the future. And that, of course, will depend on precedents and things like that. But I think ARPA-H is exactly the right institution to play a catalytic role in demonstrating the power not only in demonstrating the power of data-driven health, but in helping to catalyze the technologies that will bring health treatment from the hospital to the home. And I think that is going to be, again, an enormous revolution there. So I think what we have to be able to do is have serious projects that will be on the $50 to $100 million range that show the power of these things and develop the technologies that will be necessary for bringing the cost of phenomics down. Remember that when we started the Genome Project, the estimated cost for the first genome was $1 billion. And of course, since that time, it's come down by, 7 or 8 orders of magnitude. You can get genomes now, well, for a few $100s anyway, depending on who you trust and what you trust. And phenomics is going to come down 2 or 3 or 4 orders of magnitude. We can do a very good phenomic analysis now for $6,000 a year, and I can see the time when it'll be $60 a year.
Right. Thank you for that. This is sort of a follow-up to that, and there are a couple of questions along this thread as well. We, as a company, our members are often vocal about, what they've learned and what they want out of our program. And one of the questions I always get from our members, and it's recapitulated a couple of questions today, is, look, if you guys offer a lot, they say, imaging, quantitative imaging, biomarkers, whole genome sequencing, wearables, metabolomics to some degree, traditional blood analytes, what's the biggest bang for the buck? We always get that question. Or, another way is, geez, I only want the genome, or I only want the imaging. And Lee, you talked about how we eventually democratize this, into Africa, other maybe third world countries, and really across the 8 billion people living on this planet. Clearly, you can't easily democratize or scale whole body MRI. What do you think is kind of the most sort of scalable precision prevention analytic? And if you're going to say, blood, maybe I'll ask you to even take it further. Is it proteomics? Is it metabolomics? What's going to give us the best sort of bang for the buck in terms of these scalable diagnostics? Or is it the genome?
I think the answer is we don't know now, but I'll tell you, in the end, I think we're going to try and reduce all of this data dimensionality to wearables, okay? So we've just gotten funded a project with Steve Friend where we're actually going to make a wearable that can detect the activity of the pancreas and the ability to make insulin. Right now, to do that, you have to go into a hospital and you have before and after kinds of tests and so forth. And we think we can make something very, very simple and have it be incredibly accurate. And we'll do that by taking a lot of omic analyses and correlating subtle omic features with subtle physiologic features that are measured by various types of wearables. So I think in the end, if we really want to bring it down to dirt cheap, those are the kind of things we're going to have to do. Yeah. I think it's going to be 5 to 10 years before we do that. And in the immediate time, I think if I had to ask what is by far the most valuable, it would be blood from our point of view, because the clinical chemistries give you a whole variety of actionable possibilities. Proteins, as I showed you, have given us this deep insight into very early diagnostics and so forth. And I think there are going to be some new technologies, both for proteins and metabolites, that in 10 years may make them 10 times less expensive in their analyses, 10 to 100 times less expensive. So I think the key is going to be to push the technologies, not knowing just which ones are going to be most effective initially. But there are ways we can take what we have today and put together, I think, a very actionable program for under $1,000. a person or so. And that's something you should and you may overlap much of what's in that because you're doing the clinical chemistries and everything. But it would be curious to match what we're proposing with what you're doing.
Lee, a follow-up to that, we've got a question that sort of dovetails with your comment on a tube of blood being so important. Often we're just starting to biobank our clients' blood, and for years we saved a DNA sample, but we didn't save plasma, which frankly was a miss. But we're starting to do that, and as our listeners know, the UK Biobank has been doing that. Many publicly available biobanks, biobank serum and plasma. But I'll often get the question from our members, well, listen, I get why it's going to be useful for science. I'm willing to do that. That's partly why I joined the company. I want to be on the bleeding edge and I want to help contribute. But sometimes I'll get the question, rightfully so, well, what's in it for me? If I give you a tube of blood and every year you're storing it, is there a potential upside or benefit to me, say in 10 years, if I, develop a chronic age-related disease? Is there, something in my 10 years worth of blood data that will actually help, treat or intervene on, a potential diagnosis? What's your take on that, Lee?
My take on that is if we take that blood sample and if we do the genome, phenome, clinical chemistry, metabolite analyses and so forth, that record can be searched every year into the future as we generate thousands of new actionable possibilities. And I'll guarantee you time and time again, we'll be able to go back and say, look, this is something you have to worry about, and here's what you can do about it.
Yeah.
So, but that's one argument. I think there is the real chance you can do things for individuals. But, the other argument is, you're inventing medicine of the future, and that's for your grandkids and your children. And God knows most people are willing to sacrifice in that regard too. That was the most compelling argument we found in Arivale, was the argument that it's for your kids and your grandkids.
Yep. No, our member base, I think, is full of folks with that ethos, and we're obviously grateful. So,
but I'll guarantee you, if you have your blood done this way, and we continually search it once a year, we'll find things that'll be relevant to you.
We're believers in that as well. One last question, Lee, and then we'll close. I have a question here about the NIH All of Us initiative. I think you briefly alluded to it. Can you comment about any partnership that you have, or what you see as the major benefits of the All of Us initiative, and maybe just give an overview of it, if you wouldn't mind?
Sure. The All of Us is an initiative to do 1 million people over a finite period of time, and to analyze their genomes, to analyze some of the digital health measurements and so forth, and to get their electronic health records. Very early on, I went and argued they should do phenomics, and I got nowhere. And in fact, I think they still feel phenomics is way too expensive. Although what this program is not a program that really returns useful results to patients, but rather it's a big research program. So it's created an enormous research infrastructure on which grantees from NIH can analyze genomes or analyze electronic health records or the other things they have. So I think as a resource, it's going to be enormously useful. And of course, they've done really attempted to make it a diverse resource. It includes a lot of racial diversity and everything. So in that sense, I think it's valuable. I think what the Phenome Initiative is and how it differs is it uses phenomics to be able to return actionable possibilities and really change your health. So one is a research project, and one is we want to invest the health of the future and bring it to you as soon as we possibly can.
Well, Lee, thank you so much. I'm sure all of us learned something on this the Zoom presentation. We thank you, and thank you for our members for tuning in, and we'll see you all soon. Thanks again, Lee.
Okay, thank you very much.
Cheers.